we're going to talk about what are the questions which have been asked in FMGE 2025 exam, and I am Dr. Ramkumar, and I am a director of anatomy in Dopamine, and it's given me more amount of pleasure to share my knowledge to all of you students, and very thankful to every one of you who have been a member of Dopamine, and this year exam, with the perspective to anatomy, this year the questions were all straightforward and easy, like even previous years, there was not much of twist in many of the questions in anatomy, and so with that we will discuss about some of the questions which have been asked in this exam. Okay, so let us go with the first question. It's an image based one, where the development during the second and third week of intrauterine life, where this structure has been marked. Okay, so this structure has been marked, this one here has been marked, and they asked you what is the structure present in an adult form. Okay, so usually we studied, this, it's a remnant. Okay, it's a remnant. Okay, something it persists, do not have any function, it persists in adult life as well. Okay, the first one, what is the structure present? Okay, so this is the notochord. Okay, this structure is the notochord, and as you all know, when you have attended my embryology session, you would have known. Okay, the notochord is an axis of the embryo, it determines axis of the embryo. Right, so it forms the center. Okay, the right, the left, the superior, inferior, all determined by the position of the notochord, because it forms the axis of the embryo. Okay, so that's why the mesodome which are present on the side is called the paraxial mesodome, paraxial, which is present on the side. Okay, so now we have identified the notochord. Okay, the question is, what is the structure which forms in an adult life, which means after the fetal life, it is formed as a remnant as what? Okay, so the answer will be the nucleus pulposus. Many of you have written this one as correctly in the group which we have discussed. Nucleus pulposus will be the answer. Okay, it is present in between the intervertebral disc. Okay, as I told you, notochord forms the axis of the embryo, and it is very important for induction and patterning of the surrounding tissue. Okay, this is very important for the formation of various tissue, induction and the patterning. Right. So for that, we need one important gene called what? The signal from the sonic hedgehog gene. Sonic hedgehog gene, and as you know, the notochord disappears and it contributes to the nucleus pulposus, which is present in the IVTs. Okay, so let us come to the next question. Which nerve can be compromised in case of a fracture of humerus involving this area? Once again, this question I have taken from my discussion which I have done before the FMGE exam, before the NEET exam. Okay, we had made a set of questions in that this question has been asked. Okay, so here then an image, an X-ray image has been put, a humerus image has been put, and a fracture is present in the middle third of the shaft. Okay, middle third of the shaft of the humerus bone. Okay, and the question is, which nerve can be lesioned out here? And the choices have been given. Okay, but now before going to the choices, what will be the answer for this question, right? So what I usually teach my students is that, so what happens, when the humerus can be fractured in different areas. What I have taught my students, what happens when humerus is fractured at different sites. So what will happen? So when the humerus is fractured at the surgical neck, this part here, surgical neck, okay, the axillary nerve will wind around the surgical neck of the humerus, so which means the axillary nerve can be injured here. Okay, in the middle shaft, okay, we have a spiral groove, and in that spiral groove, okay, the radial nerve travels very closely to the bone. Okay, so which means in the middle shaft of the humerus, the radial nerve can be injured. Okay, and then in the lower aspect of the humerus, okay, here elbow dislocation with a fracture here. Okay, ulnar nerve can be injured. Okay, so different locations can be asked every time, So initially they asked, the surgical neck of the humerus, what now they've asked radial nerve. Once again, it's a multiple time. The radial nerve has been a multiple repeat. Okay, so in the surgical neck of the humerus, axial nerve can be injured. In the middle shaft of the humerus, okay, radial nerve, which is a very close contact with the humerus, can be injured. And in the lower aspect of the humerus, with an elbow dislocation with a fracture, ulnar nerve can be injured, as it is in very close relation with the medial epicondyle and the olecranon fossa. Okay, and even one student have asked what will be the median nerves there. whether it will be injured or not. Median nerve is actually protected by the belly of the brachialis muscle. Okay, so median nerve very rarely it can injure only when there is an open fracture. Okay, when the RTA is very severe, okay, when the injury is very severe and it's open fracture and it avulses a nerve, and in that scenario only the median nerve can be injured because it is highly protected by the brachialis muscle. Okay, whereas these three nerves are actually in close contact with the bone in such a way that they can be easily injured with a fracture. Okay, so the answer here will be the radial nerve. Okay. Next question, a patient had complaints of pain and swelling in the center of his right palm following an injury. On examination, he is not able to extend his middle and the ring finger. So this will be the clue here. Okay, he is not able to extend his middle and the ring finger. Okay, which of the following spaces is most likely affected? Okay, for this image, they have given an image, okay, which is actually present in your textbook. Okay, where the spaces of the hand will be present, the mid-palmar, the thenar space will be present, and how they communicate. Okay, so this picture will be present. Okay, so like that they are given an image and they have asked you which space it can be involved in this kind of a scenario. Once again, the clue here lies where the patient is not able to extend his middle and the ring finger. Okay, so with that clue we can answer this kind of question. Okay, now look at this is a typical mid-palmar space infection. Okay, and you can see this space, the mid-palmar space, communicate distally with the medial 3 web space. Okay, so its communication can be with here, the medial 3 web space. Okay, the mid-palmar space communicate with us. That is why the pus has to be drained in those kind of spaces. Okay, in order to evacuate all the pus present there. Okay, so that is why whenever in this kind of scenario, when too much of pressure, okay, when there is so much of pus accumulated, it creates an enormous pressure. That is why the patient cannot extend the middle and the ring finger. Is that clear? So the answer will be the mid-palmar space infection. You can see the mid-palmar space is actually present between the in front will be the flexor tendons here. Okay, we have the flexor tendons present here, and what is behind will be the interossei along with the metacarpal bone. Now, what is very important here will be what is the distal communication of the mid-palmar space versus the distal communication of the thenar space. Okay, for the thenar space, it is actually the first web space will be the distal communication. Okay, the first web space will be the distal communication, but for the mid-palmar space, the medial 3 spaces that include the second, the third, and the fourth web space will be the communication for the mid-palmar space. That is why IND is done in those spaces. Okay, in order to evacuate the pus completely, because it will communicate distally. Okay, proximally it may communicate with the space of Perona here. Okay, under the flexor retinaculum, it may communicate the space of Perona. Okay, distally it will communicate with the second, third, and the fourth web space. Is that clear? So the answer for this question, as the patient is not able to extend the middle and the ring, so this is a clue factor. Okay, the answer will be the mid-palmar space infection. Okay, mid-palmar space. I hope I made this statement very clear. Okay, so once again the landmark. Okay, there is a pain and swelling in the center of the palm. Okay, so in the center of palm there is only one space present, which is the mid-palmar space. Once again, an additional valuation to this one is that the patient is not able to extend the middle and the ring finger because of too much of pressure accumulated. So that is why the mid-palmar space will be the answer for this question. Is that clear? Next question, following an injury, a person presented with this kind of deformity. The shoulder, the arm is in adduction position. Okay, arm is pronated and it is in extended position. This is what the scenario has been given in an exam. Which of the following root values are most likely to be involved? Once again, in this scenario, they have made a picture of an adult, okay, falling from height, okay, where they grab some object, okay. So there is a shoulder injury, and because of the shoulder injury, the arm is in this kind of position, okay. The shoulder is adducted, remember the shoulder is adducted position, arm is extended, and it is pronated. It is not supinated, it is pronated, this kind of position. You already know the position I am talking about. It is the Erb's position. Okay, Erb's Duchenne palsy position, very common in childhood trauma, but also in case of an shoulder injury by falling in an hyperabducted arm. Okay, so this is very common, and here the question is what root value has been asked here. Okay, you already know in the brachial plexus, there are two important trunk where the injury can happen. Okay, here we have the C5, C6, C7, C8 and the T1. C5 and C6 forms the upper trunk. You already know it forms the upper trunk. It divides into two divisions. The C7 alone forms the middle trunk. The C8 and the T1 forms the lower trunk. Okay, so upper trunk injury here, and we do have the lower trunk injury here. So in case of an upper trunk injury, Erb's palsy. In case of a lower trunk injury, clunky palsy. Is it clear? Okay, so upper trunk is C5 and C6, lower trunk it is C8 and T1. Okay, so once again more and more discussion here over here. So look at the Erb's palsy. The nerves which are likely to be involved will be the suprascapular nerve, okay, and then axillary nerve, musculocutaneous nerve, and the radial nerve. So look at those nerves and let us discuss how this kind of scenario happens. Okay, first look at the axillary nerve. Axillary nerve supplies deltoid and teres minor. Okay, teres minor. So what is the function of deltoid? Deltoid is to abduct the arm. So when deltoid is paralyzed, the arm will be in adducted position. Arm will be in adducted position. Next, take this musculocutaneous nerve. So this nerve supplies the biceps brachii muscle. One of the powerful muscle in your arm which help in flexion of the arm and also supination in an flexed elbow. Not in an extended elbow. In a flexed elbow, it does supination. So both the flexion and both the supination are lost because of injury involved by the musculocutaneous nerve. So now once again let us consolidate and put the injury back here. Okay, the arm is in adducted position because of the paralysis of deltoid. Arm is in extended position is because of the paralysis of the bicep brachii muscle, and arm is in pronated position is because of the paralysis of the, once again, the bicep brachii supplied by musculocutaneous nerve. And once again, the radial nerve, the component of the C5 and C6 component of the radial nerve can also be involved. Thereby the patient will have loss of sensation over the extensor aspect of the arm and also the forearm. So these are the possible nerves which can be involved in this scenario. Okay, so the answer for this question is C5 and C6. Okay, C5 and C6 will be the answer. Okay, identify the marked bone present here. Once again, a very direct, a very basic type of question. So let us now name all those bones here. This is calcaneum. Okay, this calcaneum. This is the talus bone present here. Okay, this is the, on the medial aspect, this is the medial, this is the lateral. Okay, on the medial aspect, we have the navicular. On the lateral aspect, we have the cuboid. And we do have three cuneiform, the medial cuneiform, the intermediate cuneiform, the lateral cuneiform, and these are the metatarsal bones. Okay, so it's a very direct, very simple type of question. So identify the bone. This is a navicular bone. Okay, so on the medially we have the navicular, on the laterally we have the cuboid. Okay, so next question. A man got injured, and it's once again an image based question where they have put an image, an X-ray image where the injury is present in the lateral aspect of the knee joint. A man got injured on the lateral aspect of the right knee and presented with the foot drop. Okay, which of the following nerve is most likely to be injured? That is why, so whenever you hear the word foot drop, okay, many of the students jump to deep peroneal nerve and put the deep peroneal nerve. So in the discussion, in the group we have, okay, many of them had put deep peroneal nerve as an answer. But when you look back to the question, the injury is actually present on the right knee. Okay, so when you take the knee joint, okay, when you take the knee joint, okay, we have the femur, lower end of the femur, we have the tibia, and we have the fibula here. Okay, we have the fibula, and this is the head of the fibula, and this is the neck of the fibula. Okay, so now we already know one thing. Okay, over the neck of the fibula, we have the common peroneal nerve. Okay, the common peroneal nerve grooves over the neck of the fibula. Okay, grooves over the neck of the fibula and divides into two important divisions. Okay, the common peroneal nerve divides into deep peroneal nerve and the superficial peroneal nerve. Okay, now we can jump to the answer. What will be the answer? Is it a deep peroneal nerve or is it a common peroneal nerve? Okay, so the correct answer will be the common peroneal nerve, because the injury site is actually at the level of knee joint at the lateral. Very common, in the school children. Sometimes when teacher hit the students in the leg, very commonly that side, or a police official or an armed official hitting someone with a lathi on a lateral aspect of the knee. Okay, this kind of scenario, the patient may present with a foot drop. Okay, on a later date, they may have complaints of not able to dorsiflex their foot. Okay, this is because of injury to the common peroneal nerve, which is very superficial at that point, at the neck of the fibula. As it grooves over the neck of the fibula, it is very superficial, okay, and it is in close contact with the skin, so it can be easily injured. So at that particular space, it is divided into, that particular point is divided into deep peroneal nerve and the superficial peroneal nerve. So deep peroneal nerve will supply all the muscles of the extensor compartment. Okay, deep peroneal nerve will supply all the muscle extensor compartment, which include tibialis anterior, extensor hallucis longus, extensor digitorum longus, and the peroneus tertiaris. And the superficial peroneal nerve will supply peroneus longus, peroneus brevis. Here, there should be some other additional thing should be given in this question to prove common peroneal nerve. Inversion function is lost or eversion is lost. So when both are lost, which means the common peroneal nerve is injured. Okay, because inversion is a beautiful feature of tibialis anterior. Okay, so but once again, inversion is also done by tibialis posterior. Okay, so that is why inversion is not given here. Okay, what about the other thing? The peroneus longus and the peroneus, they does eversion. Okay, so that statement has not been given. But only one thing which has been given, the injury is happening at the level of knee. Okay, at the level of knee joint. The nerve is actually a main trunk, the common peroneal nerve is present. Okay, it do not divide until it comes to the neck of fibula. Okay, and the injury is very common in the neck of the fibula, which means the common peroneal nerve will be the correct answer, not the deep peroneal nerve. That is why you should not jump into question. So look at the picture here. You will see this is a common peroneal nerve is present here and divides into deep and the superficial peroneal nerve. Okay, so over the neck of the fibula. So neck of the fibula is grooved by the common peroneal nerve. So that will be the answer. The next question, an image-based question. Once again, students are told this is actually a medial aspect of the leg. Okay, a similar picture has been put. Okay, so a patient came to the complaints of came to the OPD the complaints of engorgement of veins on the medial aspect of the leg. Which of the veins is most likely to be involved? Okay, so once again, many of them have written this statement correctly. The answer will be the great saphenous vein, because the great saphenous vein travels in front of the, okay, it forms the medial aspect of the dorsal venous arch. It travels in front of the medial malleus and it travels in the medial aspect of the leg. Okay, so why this engorgement happens is because when the valves do not function or there is a perforatus incompetence. Okay, so perforatus are present which connects the superficial to the deep set. The blood should travel from the superficial to the deep set. So okay, and that is guarded by a valve. Okay, so when that valve fails, when the blood retrograde backflow from the deep set to the superficial set, okay, so this blood, more accumulated blood, will once again come down because of gravity, and that may cause engorgement, distension, and dilatation of veins. That is called what? The varicosities. Okay, so since the medial aspect of the foot has been, leg has been put, the answer will be the great saphenous vein. So here, two important things students have to know. One is because of the valves present here. Okay, there are a lot of valves present, and one valve is always present at the saphenofemoral junction. So when the valve fails, the varicosity happen. Another one, the perforatus. Okay, the perforatus are the one which connect the superficial set to the deep set. Okay, so we have the superficial compartment, we have the deep compartment here, we have the deep fascia here. So once again, it is guarded by a valve. So the vein, the blood which travels here should not come back. But what happens when this valve is damaged? Okay, blood may sometime flow from the deep to superficial set. Thereby, more amount of blood may accumulate on the superficial. Okay, remember this rule. No, I teach my MBBS first MBBS students. A 90% rule. When you look at the veins in the upper limb, okay, 90% of the blood traveling in the veins in the upper limb or the superficial set. Only 10% of blood are traveling in the deeper set. Okay, so let's say the example, superficial, we have the cephalic, we have the basilic vein. Superficially. Okay, so 90% of blood are present in the superficial compartment. Superficial veins carry the 90% of blood. while 10%, okay, let me write here so that you won't get confused. 90% of blood in the upper limb, we're talking upper limb, are present in the superficial vein. Only 10% are present in the deep vein. But when it comes to the lower limb, it is actually the reverse. Only the 10% of blood are present in the superficial vein. What is the superficial vein? The great saphenous vein, the short saphenous vein. Which means 90% of blood are traveling in the deep veins. Is that clear? Is that clear? So that is why, because the blood has to travel from below upwards, okay, it is tormented by the gravity, okay, which means it requires stronger muscles to compress and constrict, and the blood has to be pushed upwards, which means the blood has to travel in the deep set. It is under the enormous pressure of the muscles to pump those blood above. Okay, so remember this rule. So in the upper limb, 90% of blood are present in the superficial set, while in the lower limb, 10% of blood are present in the superficial veins. Remaining 90% are shunted to the what? Deeper set. Clear? So the answer here for this question will be the great saphenous vein. Okay, so this is what a beautiful picture, and you can see this. This is called the varicose ulcers. This is the varicose ulcer, and sometime when you practice, you will see patients with the varicose veins and the varicose ulcers. And the question arises, how does this varicose ulcers happen? No, the question lies in when you understand the physiology. Okay, so remember the veins are all thin-walled. Okay, the veins are all very thin-walled. Okay, which means whenever the blood is engorged in those veins, the veins are very much distended. Okay, with just a single lining of endothelium. When these veins are distended, what happens? The blood which is present in those veins will escape out. Okay, the blood will be escaping out of the vascular chamber, the veins. Okay, as it escapes out, we have the component RBC, the WBC, the platelets. Platelet may clump together. WBC has got pseudopods like amoeba. Okay, they may jump back to the vessel. But here the RBC, okay, in the RBC we have the hemoglobin and we have the iron. The iron is heavily pigmented. Okay, iron is an irritant for the skin. As it gets exposed to the inner surface of your skin, okay, it irritates the skin. It creates itching. It creates a kind of an abnormal sensation. The patient tends to itch. It creates an ulcer. So that is why the varicose ulcers are happening. Okay, so it's because of the iron, the pigment which is present in the RBC. Okay, that is why varicose ulcers are very common. Is that clear? Next question. This is once again, some have written anterior droid test and some have written Latchman. So what is happening here? Image has been given. Which test is performed here? Right? Okay. Now they are put in an image of a knee joint. Okay, and here you should be very keenly observing the degree of the knee joint here. Okay, degree of the knee joint. Okay. Now, for what test? For what type of this test is done? To test what this has been done is to test the integrity of the anterior cruciate ligament. To test the integrity of the anterior cruciate ligament, this test has been done. So there are two tests possible here. One is the anterior droid test here. Other one is a Latchman test. Both are done to test the integrity of the anterior cruciate ligament. And now what is happening here? Now both are done in a similar fashion. Okay, the test is done where the patient lies in a supine position. The tibia is translated towards the femur, and they'll check the mobility of the translation. Okay, because ACL is very important for the extension of the knee joint. Okay, they will check for the translation, mobility of the tibia towards the femur. Okay, now the very answer comes here with the angulation. This picture depicts here in Latchman test. Okay, in Latchman test, the knee is flexed only 20 to 30 degree. The knee is flexed only 20 to 30 degree. Okay, whereas in anterior droid test, okay, the knee is flexed 90 degree. Knee is flexed what? 90 degree. Okay. Okay. So the knee, the tibia and the femur are in 90 degree angulation. Okay. In that scenario, anterior droid test will be the answer. Okay. When there's only 20 to 30 degree of angulation present between the knee, between the femur and the tibia, then it is Latchman test. Okay. And both are done to test the integrity of the ACL, anterior cruciate ligament. And here the posterior droid test is to find out the integrity of the posterior cruciate ligament. Is that clear? And the best answer here will be, according to the image what they have given, okay, the answer will be the anterior droitus, because the angulation was actually 90 degree according to some of the students. Okay, so when it is 90 degree, it is anterior droitus, and when it is just 20 to 30 degree, the angulation between the femur and the tibia, it is actually a Latchman test. Okay. Okay, next, what is the cause of, was a tricky question here. Okay, what is the cause of esophageal obstruction at T4 level? Okay, in your MBBS, one of the important short notes is to draw and label structure present at the TS section of T4. If you recall and remember in your MBBS, okay, so T4 level is a very important thing, okay, a very important one, because at the T4 what happens, the arch of aorta begins and ends at the T4 level, okay, because at the channel angle, okay, arch begins and arch ends, okay, as an important landmark there. Okay, now coming to this scenario here, what is the cause of esophageal obstruction at the T4 level? Here, there are 4 levels given, okay, 4 levels given. The first, first you can, by means of odd man out, you can eliminate this one, cricopharyngeus, because this is the level of cervical level. Okay, cricopharyngeus present here, not at the thorax, okay. So you can rule out this one. And by order of elimination, okay, we can eliminate the diaphragm, because you should know a mnemonic called Voice of America. Because you should know a mnemonic called Voice of America, where the vena cava is at T8, esophagus at T10, and aortic at T11, T12. Okay, so this is T10. So this is also eliminated. This is eliminated, this is eliminated. Now comes the option whether it's an arch of aorta or it is a left bronchi. Okay, just now I told you, okay, T4 level marks a very important anatomical landmark, because it forms a sternal angle. It marks the T4 level. It's the starting point of arch of aorta and also the end point of arch of aorta. Is where the bronchus divides into 2, left and the right bronchus. I'm sorry, it's where the trachea divides into 2, right and the left bronchi. Okay, and this is where the acicose vein drains in the ACV. Like that, there are a lot of landmarks are present, where the mediastinum divides into superior and inferior mediastinum. Right. So among those landmarks, one important landmark will be the arch of aorta here, because there's a defined landmark at the level of T4, and the left bronchus which crosses the aorta will be at the level of T6. Okay, so at the level of T4, esophagus can be obstructed in case of an arch of aortic compression, T4. Okay, so that will be the answer for this question, because left bronchus will be at the T6 level, where it crosses, okay, the esophagus will be at the level of T6 position and not at the T4 position. Is it clear? Next question, which of the following nerves are affected in superior orbital fissure syndrome? Once again, very happy to say that, this question has been recalled, no, not recalled, this has been discussed in our revision classes just before the exam. I have put a picture of a SOF syndrome, superior orbital fissure, and we have discussed about orbital apex syndrome, and we discussed what nerves can be involved in SOF and what nerves can be involved in orbital apex. And I also made a test scenario for this kind of question, and this question exactly came here. So very happy to say this one has come as a direct question, superior orbital fissure syndrome, which means you need to know what are the structures which are passing through the superior orbital fissure. Okay, what are the structures which are passing through the superior orbital fissure? Okay, so in the superior orbital fissure, nonetheless to say, because I already discussed multiple times, okay, 3, 4, V1 and 6, okay, 3, 4, the ophthalmic division of the trigeminal nerve and the abducens nerve, 3, 4, 5 and 6. Some says the V1 and V2 branches are given, some says only the trigeminal is given, so I just made this option as an 3, 4, 5 and 6 are the best answer here. Clear? So superior orbital fissure, okay, contains third nerve, which is oculomotor, fourth nerve, trochlear, V1 division, ophthalmic, and sixth nerve, abducens nerve. So what happened when a man's, my question what I have framed at, a man sustained an injury, okay, over the sphenoid bone at the level of superior orbital fissure. What are the possible nerves which can be affected in that kind of scenario? So the answer will be 3, 4, V1 and 6. So that syndrome is called superior orbital fissure syndrome. And SOF syndrome versus orbital apex syndrome. So here 3, 4, V1, 6 is involved. So what is orbital syndrome? Is SOF plus 2. When second nerve is also involved. SOF syndrome plus when second nerve. the optic nerve is also involved. It is called orbital apex syndrome. Okay, so look at the picture there. You find this is a superior orbital fissure. You find the third nerve, the fourth nerve, the V1 division, the sixth nerve. All are traveling in the superior orbital fissure in the sphenoid bone. Okay, when there is a fracture involving that particular site, okay, so SOS syndrome will be happening. Superior orbital fissure syndrome. Okay, okay, so this is what I have discussed before the exam. Superior orbital fissure syndrome, 3, 4, V1 and 6. Orbital apex syndrome, when the second nerve is also involved along with superior orbital fissure, then that is what? Orbital apex syndrome. Okay, next, a patient presented, once again, this question also we have discussed, very happy to say, this also exactly just come in this exam. A patient presented with the ptosis and the eyeball down and out. Okay, what is a nerve? So there is no site has been given according to students who have recalled. So let me say this is the right eye, this is the left eye. So this left eye is normal, but the right eye is down and out here, like this. Down and out. So what has happened? So the patient presented with ptosis and the eyeball is now pushed downwards and outwards. Which of the nerve is injured here? So now we should know that when you know what are the muscles involving the movement of the eyeball, then the scenario will be extremely easy for you. Now, for superior elevation of the eyeball, you require oculomotor nerve. Okay, oculomotor nerve causes elevation. Adduction and depression. Okay, elevation through superior rectus, adduction through medial rectus, and depression through inferior rectus. Okay, and it also supplies inferior oblique muscle, but still, so oculomotor nerve does this action. When that particular patient wants to look straight, okay, the oculomotor nerve, when it is gone, the patient cannot, the affected eyeball cannot look straight, okay, but it is pulled by the unopposed action of this one here, of the trochlear nerve. The trochlear nerve supplies superior oblique muscle. So what is the action of the superior oblique, which is supplied by the trochlear nerve, is downwards and abduct and intort. Okay, downwards movement, abduction and intorsion. So the eyeball is placed in that particular position. It is down and out. Okay, they are not mentioned about intorsion, but it is down and out. It is because of the unopposed action of the trochlear, unopposed action of the superior oblique muscle, which is supplied with the trochlear nerve. Because the third nerve is gone, the oculomotor nerve is gone, where the superior rectus, inferior and the medial rectus is gone. Okay, so the answer for this question will be the oculomotor nerve. So once again, two kind of scenarios can be happening here. Which of the nerve is injured? Oculomotor nerve. The same, a patient presented with the ptosis and eyeball down and out. Okay, which nerve is involved here? Then trochlear nerve will be involved here. You got the question? Which nerve is injured? Oculomotor nerve. Okay, the same scenario, which a patient presented with ptosis and eyeball down and out, which nerve is involved here? Which nerve is involved here for the movement, for this movement, for the down and outward movement? Trochlear nerve. So you need to understand the question, what they are asking, and think for a second and answer this kind of question, because it may like a second confuse you. Okay, so the answer here will be since it is injured, oculomotor nerve will be the answer. And these are scenarios which will happen in case of oculomotor nerve: squint, diplopia, double vision, ptosis because of paralysis of LPS, loss of light and accommodative reflex because of ciliary muscles, paralysis, mydriasis and exophthalmos. Okay, and very important thing, the most common nerve to get involved in an intracranial aneurysm is the third nerve. Okay, third nerve. Next question, a very easy one, very simple one. A patient presented with a fish bone stuck to the pyriform fossa. During surgical removal, which nerve may be injured in this scenario? Right. So if you may recall, in your MBBS class, when they talked about the pyriform fossa, okay, it's also called the smuggler's fossa. In those days, they used to smuggle diamonds, pellets of diamonds in those fossa. Okay, so one thing, when they try to evacuate the pyriform fossa, the nerve which is in very intimate contact, a very close contact with the mucous membrane there will be the internal laryngeal nerve. Okay, the internal laryngeal nerve is in very close contact with the mucous membrane of the pyriform fossa, that it's a common nerve to get injured in case of an surgical removal. Okay, so when the internal laryngeal nerve is gone, it is a pure sensation, sensory sensation for the vocal cord. Okay, so sensation will be gone, which means the patient will have difficulty in the sensation. Okay, so the patient may sometime will have a gag reflex, and the patient may sometime may aspirate because the sensation is gone. Okay, so it is called an hidden area, anatomical and hidden area, and just underlying to the mucous membrane of the pyriform fossa lies the internal laryngeal nerve. Okay, which is a branch of superior laryngeal nerve, and sometimes any malignancy may be hidden, may cause very few symptoms, or the patient may come later to the OPD. Is that clear? So the answer, it's a direct question. The answer will be the internal laryngeal nerve. Once again, this has been adequately discussed in our sessions running off. Okay, so now with that, we will complete our recall session of the FMGE exams. So like I told you in my initial class, this year exam was actually a very easy one when compared to the previous year. The questions were direct. There were no twists to those questions, and many of the questions actually very easy, one-liner questions. I hope everybody would have written the exam well, and congratulations to all of you, and thank you so much for listening to this class. Thank you.